This conference will now be recorded.
So today we are going to see this talk of July 2020. We have finished October 2020 talks. So now we are doing articles from July 2020 talk. So the important article from this is vascular injury during laparoscopic surgery and prevention and management. Okay. So this article is about what are the risk factors for vascular injury, what's its percentages, and how to prevent it, and if vascular injuries occur, what are the common vessels and how to manage it. So the percentage of vascular injury in laparoscopic surgery, it is 0.1 to 1.1% of all laparoscopic procedures. Major vascular injury, it is associated with mortality rate of almost 8 to 23%. Okay. So major vascular injury, if it occurs in laparoscopic surgery, it results in mortality rate of 8 to 23%. Major vascular injury, they occur in 1 in 200 laparoscopies, usually during varus needle insertion or primary trocar entry. And it is the second most common cause of death in laparoscopic surgeries after anesthetic complication. So major cause of death, most common cause of death in laparoscopic surgery is anesthetic complication, and second most common is vascular injury. What are the risk factors for this vascular injury? It is a type of surgery, the patient's body mass index, and previous surgical history. Usually what happens is laparoscopic approach, it gives superior vision for this prevention and treatment of minor vascular injuries. But when major vascular injury occurs, it is more challenging. So most commonly there with major vascular injuries, laparoscopies will be converted to laparotomy. So converted to laparotomy occurs in case of 1 in 380 laparoscopies for major vessel injuries. So this is about all the percentages and numbers. Now, what are the factors which are responsible? So how you can prevent this vascular injuries? So first is proper preoperative assessment. So first thing what you have to remember is surgery, it should be done only in indicated patients. Unindicated surgery should not be performed. So this is the first. So no surgery, no vascular injury. This is as simple as that. So only in indicated cases you have to do the surgery. Second thing, the woman should be thoroughly counseled regarding the risk. Okay. So during the surgery, woman should be counseled regarding all type of risk, whatever, however minor it is. So minor or however rare it is. So you see here vascular injuries, these are very rare, but still you have to explain the patient regarding its risk. Then proper preoperative assessment should be done, like identification and treatment of anemia, so that intraoperative bleeding can be tolerated as well. Okay, so treatment, diagnosis and treatment of anemia should be done in preoperative period only, and availability of blood should be ensured in emergency settings. Okay, if the injury is encountered, then you should be ready with the blood. So, and also you have to think whether you can use this cell salvage techniques or not. Now, how you can, another topic. So first is how you can prevent this vascular injuries. So one is preoperative assessment. Second is entry technique. Okay. So as you have seen previously also, majority of vascular injuries occur during the entry. So 75% of vascular injuries, they occur either at the time of varus needle entry or primary trocar placement. Traumatic injuries, these are less common with secondary trocars because they are inserted under direct vision. So still evidence regarding which is the safest entry technique, it is still mixed, but the preference is for open Hassan entry technique to reduce the major vascular injury. RCOG recommends open entry or Palmer's point technique in women for low BMI, reduce the risk of posterior abdominal vascular injury. Now, which of this is more preferred? We can't tell. Whether it is open entry or Palmer point, which one should we choose in the first place? Don't know. There is still mixed evidence, but both techniques are recommended for the low BMI patients. Now, what is the role of abdominal pressure in case of prevention of laparoscopic injury? So, basically to see whether the entry is correctly in the intraperitoneal, whether the entry is intraperitoneal or not, to confirm that the initial varus pressure should be less than 8 millimeters of mercury. Okay, and when there are multiple attempts of this varus needle insertion, complication rate increases proportional to the number of attempts. So 64% complication occurs after 3 attempts. So after 3 attempts, the complication rate is around 64%. So RCOG recommends alternative entry, either it is open technique or Palmer's technique after 2 unsuccessful attempts. Now remember, this is a question. This is always asked SBA. So after 2 unsuccessful attempts of varus needle insertion, primary varus needle, you have to go for alternative entry technique. Either it is open or Palmer's point. Pneumoperitoneum at the time of primary trocar. Okay. So for primary trocar and secondary trocar, both you have to make the pneumoperitoneum pressure at least 20 millimeters of mercury. So why this 20 millimeters of mercury is required? To increase the distance between or vertical depth between the abdominal wall and aorta. Okay. So basically, when the 3 kg force is inserted applied at the umbilicus, if the pneumoperitoneum is created with 10 millimeters of mercury, then the depth will be only 0.6 centimeter. When this pressure is increased to 25 millimeters of mercury, the vertical distance will be 5.6 centimeters. So this is the extra length you are going to get so as to avoid the direct injury of this posterior wall vessels like aorta, common iliac artery or IVC. So for that, this extra length is required. So it should be the around 20 to 25 millimeters of mercury. The pressure is required for the primary trocar and secondary trocar entry. But what is the disadvantage of this abdominal pressure is it requires anesthetist to have extra effort for this increased ventilation. Okay. So for that, up to the insertion of trocar, high abdominal pressure should be used, and then after the entry, the pressure should be reduced to 10 to 15 millimeters of mercury. Previous surgery, again, it is a risk factors for all types of injuries like vascular injuries and bowel injuries also. So this is again a routinely asked question. Periumbilical adhesions, these are found in 0.68% with no previous surgery, 1.6% with previous laparoscopic surgeries, 19.8% with previous transverse scar, and 52% with midline scar. Okay, midline vertical scar. So remember this percentage, you have to remember. Without any surgery, the incidence of adhesions, periumbilical adhesions is 0.68. With laparoscopic surgery, 1.6%, transverse laparotomy, 19.8, midline laparotomy, 52%. So the patients who had previous surgery, alternative site should be used. And what is this alternative site? Is Palmer's point, that is 3 centimeter below the left subcostal margin in midclavicular lamp. It is the Palmer's point, which is you choose for the varus needle entry. Once the pneumoperitoneum is created, 5 millimeter trocar is inserted, and from that 5 millimeter scope is inserted, and the all area should be visualized regarding the umbilical area should be visualized for the adhesions, and then you can use the main trocar for this umbilical umbilical placement. Okay. Another thing, so for secondary, this is for the primary entry. Now for secondary trocars, other thing which you can use is tip directed entry. No, this percentage is almost similar only, Dr. Anna. See, it is around 50% for midline laparotomy, 18% for previous transfers, correct? And a guideline doesn't mention regarding the no surgeries and laparoscopic surgeries. Okay, guideline it doesn't mention regarding no surgeries and laparoscopic surgery. Guideline only mentions regarding the transverse incision and the midline vertical incision. So these percentages are almost similar. It is, I think, 55%, correct? For midline, and for this thing, it is almost same. It is 18%, I think, for transverse laparotomy. So another for secondary cannula or secondary trocar entry. Okay, 23 and 50%. Okay, so these are almost similar. See, you have to follow the guideline, but this is a recent talk. Okay, so I think see, they will not give one option, that is 18% and 23%, both options they will not give. Okay, so and what they usually ask is for midline vertical incisions, correct? So it will be almost 50%. It is around 50%. So the option will be not it will not be options like 50%, 51%, 52%. No, they will not be like that. So you can choose. Another for the secondary trocar is tip entry guided technique. So here what you can use is, see, you can see this figure. So one primary trocar is inserted. After that, one secondary trocar is inserted directly under the vision. And for other secondary trocars, for second and third secondary trocars, you can use this tip directed entry. So here what you can do, from the secondary trocar which you have inserted, you can introduce suction cannula, okay? And the secondary trocar you can directly insert through this suction cannula, so that it will, so this trocar usually it will not cause any injury. So this is the following introduction of first ancillary trocar. Suction cannula is placed via first ancillary trocar or secondary trocar and directed to the point of introduction of second trocar. The surgeon can then guide the tip of trocar into the suction cannula, ensuring that sharp tip is protected during entry and injury will be avoided. Other factors for prevention of this injury. So you should know regarding your electrowatering. So monopolar instruments, you have for monopolar, bipolar, whatever for electrosurgery, you have to see that there is no failure of insulation, there is no excessive activation. So all these things, inadvertent thermal injury should be avoided. And camera angle, it should be kept as possible as 0. Okay, so camera angle should be, camera tilt should be as close as to 0 degrees, because if the camera tilt is more than 15 degrees, then the injury is more likely to occur. So finally, the summary of all these things, how to prevent this is, use the entry technique where the operator is most familiar with, unless there are specific reasons to use alternative entry techniques. Avoid previous scars when choosing entry point. Make an adequate skin incision to avoid need of extra prods. Okay. Then if you are using the varus needle, you have to insert it vertically and stop insertion as soon as the peritoneum is reached. Consider insertion of varus and primary trocar in the supine position. Remember, this is also asked question. So primary trocar and varus needle should be inserted in supine position, and then you can insert secondary in Treadle-Lindbergh position. Increase the pneumoperitoneum to at least 20 millimeters of mercury before inserting trocars. And for low BMI or previous surgery patients, use alternative entry technique like open or Palmer's point. So till now we have seen what is the methods of prevention of this vascular injuries. Now, which vessels are more prone for the injury? So in the anterior abdominal wall, it is inferior epigastric artery and superficial circumflex iliac artery. In posterior abdominal wall, it will be aorta, common iliac arteries and veins, external iliac artery and vein, internal iliac artery and vein, IVC and corona mortis. And other vessels, this can be either omental vessels or mesenteric vessels. So we will see one by one now. So how you are going to recognize this vascular injuries during laparoscopy? So either you can see a retroperitoneal hematoma, which can be stable or expanding, which will be seen superior to the sacral promontory area, active bleeding directly from the major vessels, free blood in the abdominal cavity, or hemodynamic instability. So these are the clinical features from which you are going to recognize the vascular injuries. Now coming to the vessels, individual vessels, inferior epigastric vessel or artery. So this inferior epigastric artery, it arises from external iliac artery close to the insertion of round ligament, and then it pierces transversalis fascia and runs along the transverse abdominis muscle and the rectus shape. So at umbilicus, it lies between 3 to 6 centimeters from the midline, while at the pubis symphysis, it lies between 1.2 to 7.5 centimeters from the midline. So what is the safe zone for insertion of trocar? It should be less than 1 centimeter from the midline or more than 8 centimeters from the midline. So it is called a safe zone. So how we can identify this less than 1 centimeter or more than 8 centimeter? So we have to see the line from umbilicus to anterior superior iliac spine, and you can introduce the ports more than 2/3 of its length. Okay, so more than, you have to divide between the medial 2/3 and lateral 1/3. So you can do the insertion in the lateral 1/3 part. So it is a safe zone. Also, direct visualization of inferior epigastric artery, it can be done by transelimination in thin patients, but for obese patients, it becomes difficult. So here you can see, this is the approximate. See, this is the course of inferior epigastric artery. It can be anywhere in this faint green zone. Okay. Safest zone are this one, medial and lateral. These are the safe zone for the entry points. And in that, this yellow island is a Pinelli. He has described this yellow island, which exists between 1/3 from anterior superior iliac spine and up to the umbilicus. So you have to divide between this 2/3 and 1/3, and in the lateral 1/3, this is called a safe zone. And it can be identified easily in those with increased BMI also. So this yellow zone, it can be used for the secondary trocars. Okay, so here the injury to the inferior epigastric artery will be minimized, and you have to insert the port perpendicular to the abdominal wall. Now, aorta, usually the most common entry point is umbilicus. Okay, so for varus needle insertion, most common entry point is the umbilicus, and this umbilicus entry or midline entry, the vessels which are at risk of injury, these are aorta, inferior vena cava, and common iliac vessels. So now how this anatomy differs. So aorta usually bifurcates at the end of L4, at the level of L4. So it divides into right and left common iliac arteries. In the supine position, this position varies from 5 centimeter cephala to 3 centimeter caudal. Okay. So this L4 level varies from 5 centimeter cephala to 3 centimeter caudal to the umbilicus. And in Fredlenberg position, it again 3 centimeter cephala to 3 centimeter caudal to umbilicus. So aortic bifurcation, it occurs caudal to umbilicus in 33% of laparoscopies in Fredlenberg, while only in 11% in supine position. So this supports the insertion of varus needle and first trocar in the supine position before raising the lace into the Fredlenberg position. And this finding, these are not affected by patient's BMI. So here you can see, this is the umbilicus, and this is the relation of this aorta and inferior vena cava and common iliac vessels. If the aorta is injured, usually the hemorrhage will be visible when you enter, when you enter the camera through the scope. When you introduce the scope through the primary trocar, you are going to get this hemorrhage. Okay, but in case of small vessel puncture, the bleeding may not be visible, but there may be formation of retroperitoneal hematoma, which cannot be immediately apparent. So how you have to identify it is, so here basically the anesthetist should be listened to. Okay, so if the anesthetics raise any concern regarding the hemodynamic instability or hypotension or tachycardia, you should consider and you should see for any bleeding or hematoma. Now, common iliac arteries. Now, this is the two things what you have to remember. So, while umbilical varus insertion technique, which is the most common this thing in the midline, so right common iliac artery and left iliac vein, these are the two, right iliac artery and left iliac vein, these are the more prone to injury. Why? Because right common aorta bifurcates just left to the midline, while vena cava, it joins just right of the midline. Okay, so see this anatomy, aorta bifurcates left to the midline, vena cava commences right to the midline. So you can see during midline insertion, it is the right common iliac artery and left common iliac vein. These are more prone, left iliac vein. These are more prone to the injury at the time of varus needle placement or midline trocar. Now for venous, because the walls are very thin, okay, veins, walls of veins, these are very delicate. So injury will lead to the catastrophic bleeding. Also, the blunt dissection, if it is done around the common iliac vein, IVC or pelvic side wall, it will also result in the hemorrhage or hematoma formation. Now, corona mortis, it is an obturator and external iliac or inferior epigastric artery between it occurs behind the superior pubic ramus. So these are the veins which are more prone to damage while when we are doing this laparoscopic colposuspension, okay, or any TVT procedure, or during pelvic lymphadenectomy. So anterior abdominal wall injury, the most common vascular injury overall is the laceration of inferior epigastric artery, and which occurs during the placement of lateral trocars in the lower abdomen. So for anterior abdominal wall, most commonly injured vessel is the inferior epigastric artery. Okay. The how you are going to identify is it can be either direct bleeding from the port side or hematoma formation. Okay. If the recognition of this injury is delayed, bleeding is usually noted within an hour of transfer from the operating theatre. And delayed abdominal wall hematomas, they can occur 2 to 3 days after surgery, and it will present with abdominal wall pain or abdominal wall or flank ecchymosis. Management, here you can do the cautery, okay, electrosurgery to coagulate the bleeding point. It is the most commonly used method to arrest the bleeding from inferior epigastric artery, but sometimes these bleeding vessels may retract and then delayed hematoma formation can occur. During coagulation, it can be retracted, okay. Then another thing which can use for this inferior epigastric artery is you can just insert Foley's catheter through that port, inflate the bulb, and then retract the Foley's catheter so that the bulb presses against that bleeding point. So it will cause the tamponade effect. Also, you can do the suturing if the inferior epigastric artery is lacerated. So you can use either this endoclostridium suture, straight needle, or intracorporeal suturing. So anything you can use for the suturing, whether in what way the surgery is familiar to the method. Okay. So it can be done under direct laparoscopic vision or anything. Then percutaneous embolization. Usually the conservative management should be done if the patient is hemodynamically stable and hematoma is not expanding. Okay. But if the hematoma is expanding, then intervention is indicated, or if the woman becomes hemodynamically unstable. Here you can use interventional radiology also by percutaneous embolization of the bleeding vessel, or for rapidly enlarging hematoma, you can use this conversion to open surgery. Now, in case of posterior abdominal wall vessel injuries, so here these are the major vessel injuries. This can be potentially life-threatening. So here the vessels which are prone to injury, these are aorta, inferior vena cava, and common iliac arteries and veins. So if the patient is hemodynamically compromised and the major vessel injury is suspected, then the immediate conversion to midline laparotomy should be done. It is easier and safer to carry out a laparotomy while there is still a pneumoperitoneum. Once the abdomen is entered, the bleeding point is sought and direct pressure is applied to stop the bleeding. And by that time, you can get the help, and you can decide whether to suture. So what techniques to use to repair the vessel. So either you can use sutures, clips, energy devices, or hemostatic patches or sealants. So if the primary surgeon is experienced in repairing vascular injuries, he can repair, or vascular surgeon will be called for. Advanced surgeries which are used for this vascular injuries, these are primary repair, polytetra fluoroethylene grafts, or Dacron patch plasty. Minor small vascular injuries, this can be managed. So just 1 minute, please. Sorry. Hello, sorry for the disturbance. Okay. So the advanced techniques which are used for this vascular repair, these are either primary repair, polytetrafluoroethylene graft, or background patchplasty. Minor vessels injury, if they are occurred, they can be managed by laparoscopy only, like direct pressure application by gauze or Johann automatic grasping forceps, mastoid slabs, or electrocautery, okay, or suturings. Now, if a major vascular injury and hemodynamic instability is there, then how you are going to manage this vascular injury? So first of all, first step is you have to declare it as a major vascular emergency. Early declaration, it associated with better team results. Okay. So all team members must realize that this is a potential life-threatening situation and help should be immediately sought for. Then arrest the bleeding with direct pressure. So as I told you, it should be directly converted to the midline laparotomy and direct pressure will be applied in the on the vessel, okay, on the bleeding point. But sometimes it can, if it is possible to deal with laparoscopy, then it depends upon the skill or whether the vascular surgeon is present there or not. So always a multidisciplinary team approach is preferred. Senior surgical help should be sought for. Okay, so here leaving the trocar in place rather than removing it will limit the blood loss. So if the trocar is directly entered any vessel, so better to leave the trocar as it is, because if you remove that trocar, it is going to cause torrential hemorrhage. Okay, so it should leave it. You should leave the trocar in that place and arrange for resuscitation and repair. If the vascular injury is below the bifurcation of aorta, but it is not visible clearly, then laparotomy should be done and direct pressure on the vessel with laparoscopic instrument should be employed. Also, external pressure on aorta underneath the zipisternum can be given. Okay. Then again, you have to communicate effectively with the team. Here, you have to use this S-bar format. That is, you have to explain this complication in terms of situation, background assessment, and recommendation format so that the team understands how they have to act. Okay. So it is associated with higher team efficiency in the performance of clinical tasks and administration of essential drug. Anesthetic colleagues may delegate a member of team to communicate with the switchboard and blood bank, and major hemorrhage protocol is announced so that you can get the blood which is required. Okay, so massive transfusion may be required. Resuscitate and continue the fluid
Switchboard. Ma'am, what
rescue.
is the switchboard?
Switchboard is their main reception area will be there in that ward. No, so it is a switchboard, and from there you will get either blue call or this thing. Okay, so emergency declaration it is. Okay, then resuscitation should be done for this, and correct fluid replacement should be done. Indwelling catheter should be done, Foley's catheter, to note the urine output. Okay, and adequate fluid balance should be maintained. Monitoring and investigation should be done, like in the form of arterial lines or central lines. Intravascular access is obtained, and necessary investigations like full blood count, urea electrolytes, LFT, clotting profile, it should be done. Then other things which are required for this vascular injury. So basically, there should be a team leader should be there who should they can supervise all the team action. Okay, so they can give their inputs and they can keep the environment relatively relaxing. Okay, so close the door, don't allow other people to enter into the theater, and you can just, the team leader can manage the all supporting staff like anesthetist, circulating nurse, scrub nurse. Okay, and the extra instrument should be arranged, extra staff should be arranged. Okay, and one thing is you have to also give an idea to the woman's partner or family member. Then finally, the most important part of any complication, intraoperative or postoperative complication, is the risk management. So one team member is assigned to scribe all the events. So what do you mean by scribe? So it is a team member who will just do the work of writing down the process in chronological order. So exactly what happened, who were called for, when the blood requested, when the blood arrived, what was the patient's vital condition. So it is the just a member whose work is to only note down incidences in chronological order. Okay, and at the end there will be an incident form which need to be completed once your emergency is settled. Okay, also reflective practice should be done. So what is the reflective practice here is, you have to see exactly what was the predisposing factor, how it could be avoided, okay, in the further things, in the when you are doing this surgeries, how this complication can be avoided in future. And retrospective documentation from all staff member is useful. Then post-operative care. In the immediate post-operative period, fluid balance and hemodynamic stability must be closely monitored. It will require either HDU or intensive ICU monitoring, continue antibiotics if there is evidence of infection. Thromboprophylaxis, it should be carefully balanced regarding the risk of hemorrhage. Okay, so you can use first mechanical thromboprophylaxis followed by then drugs. Then later, it is the debriefing of the patient and her family and also with the staff. Okay, and if there is major vessel injury in the woman of reproductive age, avoid pregnancy for at least several months to allow successful healing. Okay, before the hemodynamic changes of pregnancy, they will complicate the situation further. And to prevent and to manage the injuries, most important part is training of the staff. So adequate training in laparoscopic surgery, use of hands-on mentor program, and box trainer simulator. So simulator practice is recommended for this laparoscopic training, so that the trainees can be trained for this management of such type of complication. So this is regarding the vascular injury talk. Thank you for attending, all of you. Tomorrow there will be no class. Saturday we will discuss another one. Okay.
Thank you, ma'am.
Okay, ma'am. Thank you,
Tomorrow
ma'am.
regular class will not be there. Friday.
Yes, it will be there, my dear.
Thank
It
you,
will be
ma'am.
there. I'm talking about
Okay.
talk class.
Okay. Okay. Thank you.